Psychiatric illness and HIV commonly co-occur. What are the implications for patients? Welcome to Talking Psychiatry. In this episode, I will be in conversation with John Joska. John is a neuropsychiatrist and is head of the Division of Neuropsychiatry in the Department of Psychiatry and Mental Health at the University of Cape Town. John is also the director of the HIV Mental Health Research Unit located in the Division of Neuropsychiatry. John has been a pioneer in addressing the burden of mental disorders in people living with HIV. Let's join the conversation. Great to see you. Thanks for joining me. I'm always feel so privileged that my colleagues and mates actually jump in and say, okay, we'll do this. So welcome to Talking Psychiatry.
Thank you, Christopher, and very happy to be talking to you. I'm interested to see what questions you have for me.
Oh, it's going to be a grilling. No, listen, I want to start out with the HIV Mental Health Research Unit, because I took the it's out there, it's public domain. I went to the website, impressive website, I must say. And I downloaded information, and I was impressed, John. I think you've got something really excellent going there. And I mean, you guys have been around since 2014. How did that all come about?
Yeah, I mean, it is a story, actually. So in the early 2000s, I had a colleague, or predecessor, if you like, called
Yes.
Jane Saunders. And Jane was interested in this entity of HIV psychosis. And at that point, remember, this is pre-2006, antiretrovirals were not widely available in South Africa. And Jane persuaded the provincial government and a few other sponsors to give her money towards doctoral studies. And she went and phenotyped or described clinical features of people with and without HIV who had psychotic disorders. And she was able to describe that in some detail, and that was the subject of her thesis. At the end of all of that work, she went back to the province and said, we have a real problem here, because there are people with HIV who, have serious mental disorders and are not getting access to antiretroviral treatment. The physicians didn't want to touch them because they were behaviorally disturbed. And the HIV clinicians, were concerned about giving them antiretrovirals. So psychiatrists were worried about them having HIV. So these patients fell between the cracks. And so at that point, the service was established. Jane then left South Africa, and I became the first incumbent. And in the latter part of that decade, I did a PhD study looking at cognitive disorders in people with HIV, and we were able to attract research funding. And at around 2012, there was sufficient critical mass in terms of our research program and our profile. I could go into that in some more detail, but it was enough to kind of draw a line around the work that we were doing, and formed this unit, which was accredited by the UCT in 2012, 2013, I believe.
Yeah, so I mean, that's a very interesting story. And it's always interesting to me how it starts out with one person who has a specific interest, and then it kind of evolves and grows. And I think the most important thing is that you're able to hand it over. Otherwise, it kind of ends with the person. And I think this whole issue of sustaining the initial interest has really certainly manifested very nicely in terms of this unit. So are you independently funded? Does the university fund you? How does it work?
Yeah. I mean, there are many threads to that conversation. So,
Yeah.
as a government employee, I'm employed by the province, and we have a psychologist and a registrar and a senior registrar. So in that sense, the clinical team has got long-term hard funding, bearing in mind that the HIV mental health work is kind of formally located within a division of neuropsychiatry. So that's the subspecialty in our part of the woods that deals with this group of patients. And then we would have a group of what are called soft-funded researchers. and the soft-funded
Okay.
researchers receive contract money to conduct particular research studies. And that money can kind of come and go, obviously with the cycle of research, and you'll be well aware of what's happened with, US-South Africa relations. So sustainability is a real issue, actually. You try and hang on to people, you try and mentor people, you try and build them, but sustainability really gets hammered through funding cycles.
Yeah, and I mean, that's a real concern, because one is trying to build this momentum and this critical mass of suitably qualified and interested and passionate individuals who really want to move the study of a particular area, be it HIV, be it eating disorders where I come, whatever. And I think that's always been, for me, one of the most difficult things, because certainly in South Africa, I can't speak for the international situation, there's quite an attrition of people. So no sooner do you get something going, that person leaves. And then, unless there's somebody who's really been tasked and groomed, so to speak, and with the adequate funding for all of the other things you're talking about, the so-called soft funding, actually, that funding is critical to developing the knowledge base, actually, and the credibility of the unit. So, I see it as very, very integral, and I suppose it's something that as South Africans we've kind of gotten used to. But I mean, your research is very important, and I mean, what I see in terms of the unit, you work across the lifespan, which I think is very important. The whole issue of neurobiology, but also the behavioral consequences and treatments. Do you want to speak a little bit about that?
Mm. Um, Yeah, so HIV, living with HIV has effects on several aspects of the brain and behavior.
Right.
We know,
Right.
of course, that HIV can directly infect the brain and cause a lot of damage through inflammatory and degenerative processes. And of course, this happens in individuals who are not taking antiretroviral therapy, who are not properly suppressed. And back in the day, pre-2006, that was everybody.
Yeah.
And as time has gone by, it's that window of access to antiretrovirals from the point of infection to the point of suppression that you want to try and reduce as far as possible.
Yes.
So that's the biological effect. And then, of course, you're living with a virus. So you're living with the stigma, the fear of disclosure, the fear of recrimination, the fear of abuse, with all the losses that you might have suffered through living with the virus, the stress of having to go to a clinic once a month, take
Sure.
medication for the rest of your life. So, these individuals lead very stressful, difficult lives. So they have high rates of depression, they have high rates of traumatic stress, they have high rates of substance abuse. And so our unit has spent the better part of a decade or more researching ways to try and address these kind of behavioral and mental health outcomes in people living with HIV.
Yeah, and I think that one cannot overstate the stress of living with a chronic condition that is life-threatening, which requires attention to detail at so many different levels on a daily basis for the rest of your life. And I think that, one speaks about HIV, it's so commonly spoken of that one can lose sight of just what is going on within the individual person in terms of how they manage their life. And I think it's very important that you emphasize that, because one of the other issues is that the link between HIV status and mental health, good mental health is actually critical for these patients in terms of how it impacts upon their behavior, be it sexual or substance use, compliance. So good mental health is actually critical to their survival, actually. I don't know, maybe I'm overstating it, but that's how I would look at it from what I've understood.
Yeah, absolutely. And often when you attend conferences and meetings, the epidemic is represented in terms of graphs and maps and figures. But the reality is that you have an individual living with a virus for which they need to go to a clinic, stand in a queue, be very motivated, see a long-term future for themselves, retrieve, a packet of tablets which they can store in their house, take them every day at a sort of the right time of day, endure the side effects or whatever medication they might be taking. If they have stress, they need to be able to talk to somebody. So it very much is a behavior, mental health mindset that one has to think about.
Yeah. And that's where, I think as psychiatrists, we are probably uniquely qualified, because I think we do, in terms of the biopsychosocial approach, and increasingly spiritual. And I think that we actually probably show people how things should be done, actually, for every patient, no matter what the discipline is. Which brings me to something else that you said in terms of the research unit, is that the lessons learned go beyond psychiatry, which speaks to exactly what I'm saying now, that there are things that you will learn from your research and clinical endeavors amongst people living with HIV, with mental disorders, the lessons learned which can actually move out beyond the domain of psychiatry.
Yeah. I mean, I'm not exactly sure what question you're asking me, but
No, I'm asking you just to
definitely,
comment on that observation, that actually psychiatry,
yeah,
what we do is not just confined to psychiatry. I think there are things that we know and understand that actually have a much broader application.
yeah. Well, I mean, let me come at it this way.
Yes.
In South Africa, we operate in a very territorial way. Psychiatrists are here, and
Yes.
infectious diseases physicians are there, and neurologists are there. When you enter this world and you participate in global conversations or attend international meetings, no one really cares that you're a psychiatrist. They care that you're working in the field of HIV. And so that was eye-opening for me, to go to these meetings and be amongst psychologists and neuropsychologists and neurologists and infectious diseases clinicians. What was much more relevant were the ideas and the thinking
Yes.
and the approaches, which could span, across disciplines. And in terms of translation, of course, as a psychiatrist, my learning curve was super steep, probably is still steep, to
Yeah.
understand virology,
Yep.
to understand clinical pharmacology, to understand imaging science, to understand more neurology, to understand epidemiology. So in that sense, you definitely cross disciplines in thinking about ideas.
Well, I think what you're really saying, as I understand it, fundamentally you're an HIV clinician when you step into that domain. They're not looking at, so which discipline do you come from? But I think
Yeah.
coming from psychiatry, you actually bring something more. You bring that very human understanding of people in terms of motivation, intentions, and then that speaks to behaviors and compliance. And so I think that we're kind of well versed in that, because we work with it all the time, just generally in psychiatry. So I think that's really what I was talking about.
Yeah.
But I want to get back to some hard numbers, because we've spoken about how it's represented in graphs. But I mean, the extent of people living with HIV in South Africa, I mean, I've got a figure of 7.7 million from 2019. 2024, it's about 8 million, with about 1.75 million being older than 50, so about 20%. I mean, that's quite a staggering number when you actually look at it.
Yeah, it is a staggering number. And we forget about it because, we have a cure, we have a tablet, not a cure, but we have treatment. We in theory bringing the epidemic under control. The reality is that although there's been a significant decline in the numbers of new infections on an annual basis, that number is not zero. That number runs in the tens of thousands of individuals that are still getting infected through, mother-to-child transmission, through unsafe sexual behaviors, through all sorts of things. So it's a real problem. We have a huge number of people still infected. At the same time, Christopher, the country has made great strides.
Sure.
ARVs are now widely available. We distributing them well. There's still a gap in the number of people
Yes.
who should be taking and are fully suppressed. But maybe where you were going with the question is that, in 10 to 20 years' time, we will have a significant proportion of older people living with HIV who had to endure their adult life with HIV.
Well, that's exactly. And I think that what we're looking at is what does the future portend based on that? And I mean, I've seen the figure of more than 5 million South Africans receiving ARVs, antiretroviral treatment. And I mean, again, that's a significant number. But I have a question which I don't know that anybody's ever answered, or I've never necessarily looked for an answer. Why is South Africa the leader globally in the number of HIV positive patients?
Yeah, that's a great question. I can give you some wayfinders without giving you a
Yes.
clear answer. So
No, sure.
I think that the way I've always understood it is that there are probably 4 ways to get HIV. In other words, to exchange body fluids. And let's deal
Right.
with the first being transfusions. So,
Right.
there have been little outbreaks of transfusion-related HIV, Eastern Europe and some other places. Hasn't really been an issue here. So let's park that one. You've got injection drug users, which we have small little sub-pockets of, and probably small numbers of people who got it that way. Then you have mother-to-child transmission. So when you have high birth rates in younger women infected with HIV who weren't taking ARVs or weren't taking them correctly, that was a significant driver. And then you have this notion of sexual concurrency. And in MSM, or men have sex with men in the Northern
Yes.
Hemisphere, in Europe and the US, there were subpopulations of MSM who were concurrent, having sex with multiple partners over a short space of time. And we seem to think that in that, there's a rapid transmission of the virus. So in some senses, in Southern Africa, there was a perfect storm of poverty, of concurrency, and mother-to-child transmission. And I suppose, lastly, to add, delay in the availability of widespread access to antiretrovirals.
Yeah. So it's multifactorial, as in most things. And so thanks for attempting to provide an answer, but I know that there's no perfect answer because I think it's a combination. And there are, as you say, many unique factors. So here's a question for you. I'm going to put you on the spot. Where were you in 1986? And there's a reason that I'm asking that question. Think back.
Standard 9, grade 11,
Standard
I believe.
Well, I can tell you in 1986, I was a national serviceman, a conscript. The reason I'm asking, a colleague, Leonard Eriksson, worked for the mines in those days. And he sent me, because he found out that I was having this conversation with you about HIV, and he sent me a very brief history of a patient, the first that he diagnosed with HIV in 1986. And it was a minor. He had an altered mental state. He didn't specify what that meant, with a tremor. So he sent the patient for referral to a neurologist to try and elucidate what's the basis of the tremor. He said the neurologist was quite dismissive and said, "Come on, man, that's an essential tremor. Didn't you learn that in medical school?" Leonard, not deterred or put off, thought, okay, you know what? I'm going to do a more thorough physical examination, axillary nodes, lymph nodes in the axilla. So I thought, okay, I think I'll do a lumbar puncture. Does an LP, some lymphocytes, some protein, sends it off to the laboratory and says, because he's now heard about HIV, and he says, just check for HIV. Gets a response to say, well, we don't have these kits, blah, blah. He said, just do it. Boom. HIV positive. So HIV encephalopathy with associated tremor, 1986. And so he wanted me to mention that. And I think that, when one reflects on where we are now, 8 million cases later in 2026, so we're talking 40 years. He saw his first case, now sitting at 8 million. I mean, that virus has, getting back to the whole issue of why here, how come us? Certainly it's propagated. So I thought I'd just share that. He wanted me to share that, and I said I will honor it because I think it's a nice piece of history. So the issue of HIV and the impact on the mental state, because I think that's very important in terms of psychiatric illness. And, I think when one typically thinks of psychiatric illness, I think of major depression, schizophrenia, bipolar disorder. But of course, the neurocognitive disorders sit squarely in that. So do you want to elaborate just a little bit about what that's all about in terms of how does the virus impact to cause neurocognitive disorders?
Yeah, so that's an interesting story because, there's a clear neurobiological narrative there, but there are also some political stories. And of course, any great medical space has got its politics. So
Yes.
the short neurobiological narrative is that we think that, so HIV is a lymphocytic disease. It invades lymphocytes, and that's how it spreads around the body. And any tissue in the body that is lymphocyte rich is full of HIV. And there's certain receptors on those lymphocytes, CD4 and other receptors that the HIV will bind to. And so if your lymphocytes get infected with HIV in your bloodstream, through your genital tract, they will find their way into the central nervous system, cross the blood-brain barrier, in most cases quite early, probably within weeks to months of infection, and then they will seed out in the central nervous system, and from there infection will spread in the central nervous system in lymphocyte-like cells called microglia. So microglia are the immune cells within the central nervous system, and when they become infected with HIV, they get extremely activated, and they will start enlarging and binding to each other and secreting these inflammatory cytokines, and typically congregates in the deep parts of the brain, the deep gray and the deep white matter, and through that inflammatory process begin to destroy and damage the white matter tracts and the deep gray parts of the brain. And after, with that happening, that leads to a range of neurocognitive effects, but will typically cause what we in psychiatry neurology describe as a subcortical encephalopathic picture. So the brain cells themselves, the gray matter, is not directly infected by HIV. It's the subcortex. So those connecting tracts and those connecting fibers get damaged, which leads to slowing, leads to tremor, leads to rigidity, leads to apathy. In fact, that picture that Leonard very nicely described in his minor back in 1986.
So in fact, in many respects,
get set up.
So in fact, in many respects, that was almost like a classic presentation.
Very much so.
It's amazing, actually.
Yeah,
and one didn't know what one was looking at. It was just an index of suspicion. You've heard the rumor, there's something going on. Boom, there it is. Sorry, John. So but I mean, from what you're describing, it sounds like a destructive havoc up there in the brain once the virus gets in.
I mean, if you look at MRIs of patients who have established HIV encephalopathy or HIV encephalitis, those are interchangeable terms, you'll see very diffuse and widespread damage across the whole subcortex of the brain, enveloping the ventricular system, reaching across all lobes of the brain. I mean, those are worst case scenarios, of course, not going to happen in everybody necessarily, but definitely in untreated cases. Let me emphasize that. Untreated cases can cause quite rampant encephalopathic disease. Mind you, just Christopher, to say as well that it is a multi-system disease. So it's not just a brain disease. These patients with untreated HIV, they have lung infections, they have pneumonias, they have cancers, they have, emaciation, what they call a wasting disease or slim disease back in the day.
Yes. So, I mean, for me, you've put the brain very much front and center whilst also saying, it's not exclusively the brain. But I'm not sure that people necessarily always conceptualize HIV in terms of such a brain-focused consequence, actually, in terms of HIV. That's, I'm thinking of myself that yes, we know about it, but I'm thinking the sort of general perception about HIV is not necessarily about the brain. Or am I
No, it's
wrong
not.
in that sense?
No, it's not. I mean, thinking about it from a diagnostic point of view, if you look at criteria for stage 4 disease, WHO criteria, there'll be a long
Yes.
list of things, starting with the chest and the cancers and the skin and, various parts of the body. And of course, the brain is slid in there.
Right.
And probably the reason is, what is it that brings that patient to clinical attention?
Right.
And the answer is they're coughing, or they have breathing problems, or, they've collapsed. It would be seldom the brain issue that brings them to clinical care. Why? Because they're apathetic and slow.
Right.
So to be a small group of patients who present with aggression, and that
Okay.
would be a focus.
So I wanted to touch on an interview you gave for a publication called Spotlight earlier this year. And I think that you really made a very powerful point in terms of antiretrovirals and the need for immediate commencement. And I mean, I know immediate would be ideal, which is highly unlikely. But I mean, I think that what we're talking about speaks to what you had said.
Yeah, absolutely. And it's that one can look at it actually so interestingly through an individual lens, at the same time as the way that an epidemic lens. So, at the start of it, there were no antiretrovirals, so you were fully exposed forever, to HIV. And as antiretrovirals, there was one antiretroviral, there were two antiretrovirals, then there was triple therapy, which we call either combination or highly active. Nowadays, we just call it
Yes.
art, because art is art. It's one
Yes.
pill with three medications in it.
It used to be
And
hot.
it used to be hot. Now it's just art. It's just art. It's one thing. Although we can have a conversation about the long-acting antiretroviral medications later, perhaps. But
Right.
for now, it's one tablet a day. And, because your brain becomes infected, we think, weeks to months after, the first point, the sooner that you take your ARVs to eradicate, you want to remove the effects of the virus on the brain as quickly as possible, because the more time the virus has to be in your brain to set up inflammatory cycles, to set up neurodegeneration and tissue loss, you'll be left with that. You're never going to get your nerve cells back. So it's that duration of untreated exposure that's really critical.
Yeah, and I think that's the point, because essentially we're talking about irreversible brain damage. And I mean, I'm sort of thinking about adolescents who are infected with HIV. You've got this developing brain that's not
Mm,
fully developed.
mm,
You put the virus in there, which is doing what it does, and what are you left with? And so I think
mm.
that is so profoundly disturbing, actually, when I think about, well, what the hell is going on with that brain, and what are the future implications when you speak about irreversible brain damage?
Yeah. Yeah. I mean, there's obviously youth is one thing, and there was a whole group of youth who were infected vertically, and grew up through the first months to years of life with absolutely early brain development in the face of rampant HIV infections. So, those individuals would be left with a range of learning difficulties and deficits throughout their lives. Youth that become infected, in fact, interestingly, younger women, particularly vulnerable group, 15 to 25, even now, becoming infected with HIV. If they don't get early access to ARVs, their brains are at risk let's not be dramatic, probably over the course of years. As time goes by, more and more tissue loss, leaving what we call legacy effect. So tissue that can't be regained or recovered, drops off their cognitive reserve, puts them at risk of mental disorders and even late life dementias as they begin to age.
So, I mean, this is the real concern, right? About the future burden, in a
Uh,
sense, to families, well, to individuals, to families, to society, communities, and the country as a whole. I don't really see that written about much, but maybe I'm not reading the right literature. But as we're having this conversation, I'm thinking, this is profound, especially when we go back to the numbers that we're talking about, the 8 million. Any drop off in compliance, and you are into this potential cycle, because you look at the issue of cognitive health. And I think that's what we're really talking about is cognitive health and the power of the antiretrovirals. I mean, in terms of preserving function, promoting function, and preventing decline. I mean, those are significant impact that the ARVs have.
Yeah, it's interesting, the politics of it, through the epidemic is the concerns and the research into aging and HIV is definitely a focus now, probably brought into focus in the last decade as the researchers and the funders started to wake up and think, hang on, we're not going to get rid of this virus. These people are on treatment, but they have low-grade inflammation or they've lost tissue, and they're getting older now, and we're starting to see dementias. We're starting to see declines in cognitive health. I guess 2 points to make about that in terms of South Africa. The one is, the 8 million people you refer to are quite significantly represented by disenfranchised, peri-urban, rural, relatively unemployed, relatively low education. So the advocacy, in my view, has not been, where it should be. And I suppose, sadly, South Africa's advocacy for HIV has probably not been the best. And secondly, African samples and African studies are few and far between when it comes to the research space. When you look at, Lancet publications, there are very few papers that are contributing to it from Africa and from the global south.
That's a real issue, I mean, if one looks at the potential burden, and I'm thinking who should be in the forefront, and I suppose you might think neurologists, but actually psychiatry, in terms of having the neurocognitive disorders within DSM-5, Diagnostic and Statistical Manual, issue version, whatever you want to call it, number 5, we might potentially be the ones who are in the vanguard of pushing that agenda, because I think that at the end of the day, it's not exactly with all the other psychiatric conditions that we deal with bread and butter, but it's certainly a prominent group of conditions. And so I'm wondering where the advocacy should be coming from. And it strikes me as we're talking, why not psychiatry? Because, I mean, at the end of the day, this is what we do at some level for certain of us.
Yeah. It's a two-edged sword, in my view, because, as you know, psychiatrists are seen as a, fringe specialty in South Africa. So I think first prize would be to hold hands with neurology and infectious diseases. And I would say, in my journey over the last 20 years, I've developed really good relationships with mainly the infectious diseases clinicians in Southern Africa.
Yes.
There's a society.
Yes.
I've been to their conferences and presented at their conferences fairly frequently. And I think there is definitely a space for more than there is now, advocacy for cognitive and brain health. I think there's a recognition, and maybe this is also an epidemic. This is a reflection on the epidemic. In the first, 15 years, we were so concerned in just getting those ARVs into people that was the focus, like get them onto the pills. Now, there's that last hard to find, hard to treat, hard to reach group of people, and that there's a realization that this is where psychiatry, this is where mental health, this is where behavior has a real role. Those are the patients who are struggling with mental disorders or denial or, lack of support. And here we can really play a role, I think.
Well, you mentioned stigma, and something that hadn't occurred to me. There's much that hadn't occurred to me till I started looking into this. And I've got to put myself as one of those psychiatrists. Yes, HIV and psychiatry. In fact, I self-published a book for Rita Tom on her PhD, which dealt with heart, highly active antiretroviral treatment, and mental illness. So I had an involvement then, but I kind of, went along a different path. But just thinking about the subject as maybe your average I put myself as an average psychiatrist in that sense. I'm now starting to think slightly differently through this conversation and just reading up and touching base with some of the issues that we've been speaking about. But along this, the issue of stigma, obviously, psychiatrists and other medical disciplines, yes, we know all about
Mhm.
interdisciplinary stigma, never mind any other
Yeah.
stigma. But you mentioned something interesting in that conversation or that interview that you had with Spotlight, and the issue of the stigmatization, the double stigmatization of being HIV positive and having a neurocognitive problem. Do you want to speak a little bit about that?
Yeah, I mean, I think I would enlarge it to say having HIV and any mental disorder produces a double stigma. And, um, you know, people don't speak about mental disorders in general. So if you have depression or anxiety, that's not spoken about. You're seen as weak. If you have a serious mental disorder, you're seen as crazy. Now you've got to manage that on top of managing the stigma of having a dirty disease that you can infect people with. And so it requires a particular kind of clinician, who's actually got quite an open mind to
Sure.
dealing with those patients. With a mindset switch that has to happen across the board, actually, in primary healthcare, where a lot of our focus has been.
Well, I think that, as I said, the issue of stigma, I hadn't thought about it within that context specifically because one always thinks about it within a very specific context about psychiatric
Ah,
patients generally. But there was another aspect to that, which was the issue of screening. And the fact that the kind of screening that takes place for neurocognitive disorders to see if somebody does or doesn't have one might in fact be an overestimation of the degree of dysfunctionality, and that might be a problem in itself. Any comments on that? Because there are traditional screening tools,
yeah,
but I think the discussion was around a much broader conceptualization of functionality, not just a number on
yeah.
a scale.
Mm. So this goes back to the politics where, back in the day, we spent a lot of time characterizing cognitive disorders in people with HIV who weren't taking ARVs. And there was a lot to see and a lot to find. Um, it moved towards characterizing cognitive performance in people who were on ARVs and in trying to describe it across the globe and describing it in South Africa, one makes use of test batteries, what are called neuropsychological test batteries. And it turns out this is much, much harder than one thinks because you take tests that have typically been developed in Western situations, and you apply them to South African situations. You try to obtain as best you can locally appropriate control data or normative data, and you report on it. But we've started to find that there's this disproportionately high signal in people with HIV in terms of their test performance and fairly low impact on day-to-day function. That's the first point to
Ah,
make.
so there's a bit of a disconnect.
There's a disconnect. And so we've started to investigate why it should be that people with HIV are performing more poorly on testing. And it turns out that the signal from early childhood, from schooling, from socioeconomic situation in the sample, in the HIV sample, is quite significant and may contribute to some of the variance in some of the test performance that you see when you do it cross-sectionally. So we do think that there's a significant risk of over-reporting and over-diagnosis. Uh, we do think that there's a risk that if you screen people who fall below a certain cutoff, that you risk diagnosing something that is not significantly impairing and raise the levels of anxiety to unhealthy levels.
Well, I suppose it speaks to my issue. I think I might have alluded to it in a previous podcast on rating scales and the meaning of a score and the meaning of a number. And often to get to significance, it's a couple of points. And, you really have to be very careful how you interpret. And I suppose what I'm understanding is context. You've got to actually contextualize the findings within a whole range of other variables which could be impacting. So one needs to look at finding a measure that is more representative, ultimately, of the individual. So the emergence of psychiatric illness, do you have any specific prevalence data or any data on what percentage of HIV positive patients might manifest with mental disorders?
So let's start at the top with neurocognitive disorders.
Okay.
If you were to look at it in a group of people who were untreated, then some people say that HIV dementia occurs in around 15 to 20%, 1 in 5 people. If you give them treatment and they're thoroughly suppressed, we think it's closer to 1 to 3% of people. So that is major neurocognitive disorder. The problem with things like depression and anxiety is there's such heterogeneity in terms of the samples. Very few samples or studies are controlled. In other words, they've measured the prevalence of depression at the same time in HIV negatives and HIV positives. And so there have been meta-analyses published 20 years ago where there was a suggestion that major depression was twice as prevalent in people with HIV. But I think that the more reasonable data suggest that depression is probably 20 to 30% more prevalent in people with HIV, and that in African populations, the estimated prevalence of MDD, or the 12-month prevalence of MDD, is about 15 to 16%.
So, that's much bigger than in the general population, much higher figure than in the general population.
It is. Yeah, it is a high figure. Yep.
So, I mean, there's a definite need for awareness, vigilance, because coming back to what I'd said earlier about how good mental health has a positive impact on a whole range of variables related to behavior, sexual compliance, you name it. What about the vulnerability of psychiatric patients to acquiring HIV? I'm going the other way now. How vulnerable are psychiatric patients to acquiring HIV?
Yeah. So, I mean, this is an epidemiological question. When we first looked at it, the underlying assumption was if you had a severe mental disorder, your judgment was impaired, your ability to communicate was impaired, your ability to negotiate safe spaces was impaired. You may be dependent in terms of finances on other people. And so you were at high risk. You couldn't negotiate condom use or lubricant use or whatever you needed. Perhaps you weren't in a stable relationship. There were all sorts of those sorts of things going on. In low prevalence populations in the US, where HIV was 1% or something, the early studies suggested that people with severe mental illness were about tenfold more likely, the odds of acquiring HIV were tenfold compared to those without severe mental illness. The South African studies, because, admission populations in acute units were, people from 18 to 50 normally, HIV prevalence there was probably 10% anyway, 10, 15%. So in order to try and measure odds and risk ratios for HIV acquisition, you would have required very, very big sample sizes. So we were not able to show in South Africa super high prevalence of HIV or risk for people with severe mental illness. But intuitively, you would think that would be the case.
Yeah, no, I think that's correct. The fact that one doesn't necessarily have definitive data doesn't diminish the fact that you can look at your patient and you can look at some of the risk factors in terms of their vulnerabilities, impulsivity, decision-making, etc., as making them more vulnerable. And I would imagine when you have the dual burden of psych illness and HIV, it's got to have an impact on outcome.
Absolutely. You're talking about people with severe mental illness who seldom go to clinic, often don't make their first appointment. Now they've got to go to a different clinic. They have to go to an HIV service. They have to take their antiretrovirals. So they definitely face a lot of challenges. And in the early days, we spent many hours talking with the ID docs about getting our severely affected patients onto antiretrovirals, with them saying, we have to wait till they're apsychotic, we can't start them on drugs. And we would say, well, they're not going to become apsychotic unless you give them the drug. So it was
Exactly.
a round and about thing. Yeah.
Yeah,
Yeah.
exactly.
So we ended
And
up saying, look, we'll hang on to them for 2 months, we'll make them better. We'll keep them a bit longer.
I mean, that's kind of interesting because I'm thinking about the impact of the virus on the brain. You're trying to
Uh,
manage a psychiatric illness, which is potentially being worsened by the virus. And they're saying,
uh-huh.
well, when the patient is better, settled, send them back to us for antiretrovirals. And you're saying, no, but if we put them on antiretrovirals, they potentially will settle far quicker because we're
Yeah.
eliminating that contributor to what is going
Yeah.
on. Because it's very difficult. How do you tease out what's the virus? What's the de novo psychiatric illness?
It is difficult. I mean, just to go back a step and say, in those days, we had, access to antiretrovirals was limited. We had a small number of antiretrovirals, and if you weren't taking your pills with great regularity, you were at risk of becoming resistant to those antiretrovirals. And in fact, the ID docs used the term, oh, that guy blew his first line. It was almost like, you've exploded your first line. I can have this image of the brain going, exploding.
Right.
So
Exactly.
they were very territorial over their ARVs. Nowadays with dolutegravir, very robust.
Yes.
Probably at adherence is down to 80%. You're getting good suppression rate anyway. So I have to say, though, they were generally good. Once we calmed
Yeah.
them all down, they were
Yeah.
generally helpful in giving us ARVs.
Well, I suppose the obvious solution to my mind would be that psychiatrists in those circumstances should dispense antiretrovirals. Because I mean, it's
Yeah.
almost part of this. It's almost part of the psychiatric treatment. Because you said, okay, well, this person is HIV positive. We know that there's stuff going on in the brain as a consequence. They're in front of us. We're having to work
Mm,
with compliance issues anyway. So we slap in
mm,
an extra medication. And maybe we bring the whole situation under control more rapidly. I don't know if that's a realistic option, but I mean, it just occurred to me
yeah.
as we were talking that would be
Yeah.
an obvious. How comfortable psychiatrists would be to prescribe, but I think it's got a lot to do with familiarity and,
Yeah.
getting. So I don't know. Is that something that's
That's a good
feasible?
one. I mean, back in the day when ARVs were, if I could say, precious, we decided not to do that. And I took a decision not to prescribe ARVs.
Okay, fair enough.
Um, and because I had good working relationships with ID docs, I do know that Greg Johnson, whom you know,
Yes, very
had the
well.
opposite view. So Greg was a prescriber of ARVs, and he felt confident to do so. I think in
Right.
my mind, I would have wanted to do a diploma in infectious diseases or diploma in HIV medicine in order to do
Fair
that.
enough. Fair enough.
But I never really saw the need to do it, call it lazy, whatever. But, this is a different field of medicine,
It is.
those
It
drugs
is.
are not uncomplicated. They cause renal issues. They cause weight gain. There were all sorts of lipodystrophies and other things.
And now you get into the technical aspects of prescribing drugs
Mm,
outside of your domain. And
yep.
then we get into issues of liability based on training and expertise. So yes, so
Yeah.
it's a nice idea if you feel competent enough to do it. Okay. If not, also understandable. But that brings
Mm.
me to a study that you were a co-author of. I don't know if I'm going to get the pronunciation of, it sounds like REFUE. RUFFIEUX. I don't know how you pronounce it exactly, but you were a
Yes.
co-author back in 2021. So it's a few years back. And this was
Mm.
looking at the treatment gap because we're talking about
Yep.
treatment now. And I mean, when I was looking at the treatment gap in terms of the impact of psych illness on HIV outcomes, and the treatment gap being the difference between who's got it in terms of the illness versus who receives it in terms of treatment, there were some pretty stark findings, actually, in terms of the undertreatment.
Yeah, it's
Do you, re-
scary.
do you recall the specifics? Because I can remind you.
Yeah. No, you can, but there's a graph. I think there's a graph which shows differences in public sector versus private sector
Yes,
treatment coverage.
yes. It's mind-boggling.
Yeah, and makes a case for the NHI, in terms of the disparities. And I think the treatment gap could be as high as 90%, if I recall correctly.
No,
Yeah.
the actual, in the private sector, 40.5%. And by the way, I'm not a proponent of NHI. I've always said fix the state sector and you don't need NHI. That's my feeling. And when I look at being a decades long, in fact, I was only ever employed in the state sector, so I have a sense of what it needs. And I remember being at a meeting, political meeting, and I said to the guy who was advocating for NHI, I said, but if you fix the state sector, you don't need NHI. But you've got to fix the state sector. There's no shortage of money, but there's definitely a shortage of how, or should I say skills, in terms of how it's spent. But that's a whole nother discussion, and I'm not going to get into
another
it.
Podcast.
Another podcast, NHI. So the figures were 40.5% in the private sector, which is high enough, 96.5% in the state sector, and 65% in public tertiary care programs. So that is like hospitals affiliated to an academic complex. So I mean, the numbers receiving appropriate treatment are small relative to what's required. And I think that, this whole private state, okay, you can look at 40 versus 96% of undertreatment, but even in the private sector, 40% is...
Yeah, it's pretty bad.
That's like, that's 4 in 10. So I think that the issue, and then of course, the paper went on to drill down further into specifics regarding antidepressants, anxiolytics to relieve anxiety, antipsychotics. And I mean, the rates of treatment in the public sector versus the private sector, 17 times lower in terms of antidepressants, 50 times lower in terms of anxiety-relieving drugs, but only 2.5 times lower in terms of antipsychotics. So we're pretty liberal with our antipsychotics in the state sector, but man, anxiolytics and antidepressants, poor. So it's there's the overall treatment gap, and then you get into the specifics of the specific medications, and there's a significant undertreatment. Your thoughts on that, John?
Yeah. Look, I can only try and explain it in terms of understanding what happens at primary healthcare. And I think a lot of that data would come out of first contact situations in primary healthcare. And you look at the average primary healthcare clinic in South Africa, you've got several thousand patients trying to get care for a range of conditions where the contact time between clinician, be it nurse or medical officer, is so limited that what they don't want is for a patient to go in there depressed, crying, suicidal, and so they're not going to be opening that can of worms. And I think there are a significant number of barriers at that level to actually looking for and prescribing antidepressants and anxiolytics.
So, I started out this conversation reasonably calm, but as I'm getting deeper into the issues, I'm starting to get a little bit more agitated when I think to myself, come on, man, this is completely unacceptable. And don't you understand the consequences of untreated or undertreated mental illness in terms of this population? And as I said, for the individual, the families, the communities, the society, the country as a whole, I mean, there's significant implications. Okay, so I'm sounding like I'm on a political rant here, but, I do feel strongly. So one of the issues for me, some of the earlier treatments, efavirenz, and the precipitation of psychiatric side effects and where we've gone to now in terms of dolutegravir. So your thoughts on that?
Yeah. So we had to work with what we had. So, efavirenz, great drug, backbone, of a lot of the early regimens. We knew that in particular individuals, in fact, in quite a significant number of individuals, there would be early neuropsychiatric effects. People reported dreaming, they reported sleep issues, maybe even early anxiety. Then there was a group of people who became psychotic on efavirenz. And there are some genetic predispositions to that. There's some genes from just north of our borders, some Zimbabwean individuals who had
Interesting.
inability to metabolize efavirenz at very high levels of metabolites of efavirenz, who became psychotic, often with neurologic signs. And we then did a study led by Sam Nightingale, funded by the UK and South African MRC, in which we were able to naturalistically observe the switch in the program in individuals taking efavirenz to dolutegravir. And we also included in that study controls. So we measured cognitive performance in people on their efavirenz and controls, and we picked them up 8 months later once they'd switched to dolutegravir. And the I would say frightening, but actually very comforting outcome was that the people who were taking dolutegravir started to look a lot more like people who were not HIV infected. So our conclusion was that to some extent, efavirenz was contributing to impaired cognitive performance.
Interesting. So the treatment was part of the problem.
Yeah, the treatment seemed to be part of the problem, correct.
So without getting too technical, I mean, these are obviously two drugs that have different mechanisms of action, but ultimately what they both do is reduce the viral load. And so that's the basic outcome.
Yeah.
Also, what I'd understood with efavirenz was that there was a tendency towards developing tolerance, and you invariably needed to add a second agent to compensate for that.
You would break through, so quite high levels of efavirenz resistance in the community. Like I said, adherence rates between 90 and 95% required in order to maintain suppression. Yeah, whereas dolutegravir, as you say, technically is an integrase inhibitor, so more robust. And the virus tolerates, or rather doesn't tolerate, lower levels of adherence, which is good.
Fantastic. So the one thing that did strike me is that if you have a drug that precipitates psychosis, surely an interesting study to understand the etiology of psychosis based on the mechanism of action of the drug. I don't know. It just crossed my mind as I was reading about it.
Perhaps, but we have other psychotogenic drugs like cannabis and
absolutely,
cocaine.
So again, multifactorial, different mechanisms of action.
Yeah,
so I think that's one of the issues with psychiatry. Nothing is straightforward, and I think that's the beauty of psychiatry is that it keeps us on our toes as psychiatrists and thinking creatively. So I wanted to put something your way. A very recent development, maybe not such a recent development, but it's received quite a bit of attention. And the issue of a vaccine for HIV, because I spoke to somebody who's involved in the development, without naming names. And my question was, okay, who are you going to, specifically, who's your target population for an HIV vaccine? And I hadn't considered our psychiatric population. It just hadn't crossed my mind until I started preparing for this episode. And I thought to myself, where does that fit into patients who might be vulnerable for acquiring HIV? Would that be a potential population? I'm not saying they are, just a thought. Your thoughts?
Yeah, I mean, traditionally, the vaccine sits alongside the pre-exposure prophylaxis kind of literature and practice. Yeah, so pre-exposure prophylaxis is being touted to be best used in people at high risk of HIV. So, obviously would be people with high sex burdens, so sex workers, MSM, who are identified as being people having regular sexual intercourse. But then there's a group of people unprotected, unprotected, unlubricated. And then there's a group of people who are quasi-vulnerable, that younger female population who you want to get into because we know from the epidata that they're becoming infected, that there's some sociological and relationship factors that are driving infection, yet they might not quite see themselves as vulnerable. So that's been a lot of the work, is to get into these communities of younger vulnerable women talk to them about the way that they're having sex and say, here's a way to protect yourself from HIV. It is a thing. If you're at risk of acquiring it, take the pre-exposure prophylaxis. Interestingly, the mentally ill population, perhaps you're talking about those with severe mental illness.
Before we get ahead of ourselves, they first got to get the vaccine. And I think it's going to be difficult, to be honest, which is not to be nihilistic, but obviously, one must be realistic. So I think one of the big issues for me, coming back to neurocognitive issues and just in general with psychiatric patients, HIV, is the issue of compliance. And I think that, certainly that is your best mitigation, I think, against all of the ills that emanate from the virus in terms of the brain. And I suppose psychiatrists are pretty well versed in issues around compliance. And so the kind of psychosocial is very much where psychiatry can contribute to that. So, John, the interventions are clear. The availability is an issue. Treatment gap, compliance, there are a whole number of factors. And I think that the potential for a greater burden on our health services is potentially still to come based on neurocognitive problems and the number who are over a certain age and all of the issues that we're talking about. I think that the situation is actually really very, very dire. Without being dramatic, and I'm not really a dramatic person, but I mean, so who's listening? I suppose I'm just a little bit concerned, and I'm coming from my own perspective as your average psychiatrist. Maybe there's a bit of HIV fatigue. I don't know. People are kind of saying, oh yeah, it's under control. Antiretrovirals, it's treatable. It's a chronic disease now. You live with it, and it's kind of been parked. But in fact, there's this underbelly that actually could become much more prominent in time to come. And it seems to me that unless we get on top of it now, it's going to come. So I don't want to end on a nihilistic note, because I think there's been tremendous progress that has been made. And I think that in terms of our discussion, we're just kind of unpacking some of the issues, and maybe, there will be other thoughts that emanate from that. So John, I want to thank you for your time. It's been a great conversation. I've enjoyed it, and I've enjoyed looking into it, and it's kind of, conscientized me. I've really been thinking about it now. So I'll be going out and talking about it more than I would have ordinarily. So all the best to you, John, and your unit, and we will speak again. Cheers. Thank you for joining this episode and being part of the conversation here at Talking Psychiatry. I hope you found the episode informative. I look forward to seeing you again next time. Please feel free to comment, do subscribe, and until then, take care.